I run a independent family practice in Asheboro, North Carolina, and I have used this technology in my office since 2018. So I have a lot of familiarity with it, and I really love how it's transformed heart failure management in our practice. Go ahead to the next slide, John. So, why is this our problem in primary care? Well, because there are not enough cardiologists or access to cardiologists for them to be managing this in their office. You know, when the cardiologist gets involved in heart failure, he sees the patient when they're admitted to the hospital. My goal of taking care of my patients and my goal in value-based care contracts is to keep the patients out of the hospital. And that's why I love this technology. Next slide. So what happens currently with traditional skills in the exam room? You know, we are looking for weight changes, and those can be inconsistent. We're looking for patients to have symptoms like shortness of breath, orthopnea, paroxysmal dyspnea, edema, crackles or rows on lung exam, maybe an S4 gout. Those symptoms are late markers. By the time you're seeing those symptoms, your window for being able to intervene with oral Lasix or your diuretic of choice is probably closing. And so that's why we don't manage to keep those patients out of the hospital. If you use those traditional tools, you're risking undertreatment, and those patients can end up in the ER. They always get admitted. Or if you're overtreating, on the flip side, you're risking damaging patients' kidneys, putting them to acute kidney injury, causing hypotension, electrolyte imbalances, and then they can still end up in the hospital. So, how do we handle this? Next slide, please. Patients don't typically come into your office and say, I think my heart failure is out of control. What they will say in the manageable early stages is, I'm just a little tired today. I just don't feel like going to Walmart and walking all that way. They might report a little bit of shortness of breath with exertion, but not shortness of breath just sitting there. They may or may not notice any difference in their daily weights, and their exam may look pretty normal. Their vital signs are stable. Um, and yet, these are the people that end up in a couple of days. If you do nothing, if you just listen, oh, they're okay. It's just a slightly tiring day and they're really fine. Their heart failure is stable. Those are the patients that a couple days later you get the call from the ER that they're there in overt fluid overload. Next slide. Next slide. So hemodynamic congestion precedes these clinical signs that we look for on physical exam by days or even weeks. Patients can feel and look stable right up to just before they start rapidly decompensating. And by the time those symptoms are worse, your window for treating them in the outpatient arena has closed. Next slide. So again, their symptoms are very subtle. Slight activity intolerance, mild fatigue, a little shortness of breath, nothing really outstanding. But what's happening is underlying fluid is already accumulating in the lungs. Pulmonary pressures are rising, and that window for intervention is closing. Next slide. So exam isn't super sensitive, symptoms like physiology. Patients don't come in and say, my heart failure is worse. How do we know what to do? How do we manage these patients better? Next slide. What we need for the appropriate management of heart failure in our primary care offices is some way to measurably judge where a patient is. We need objective numbers that can tell us exactly where they're at with their heart failure, just like we use blood sugar to manage a diabetic. Next slide. So the REDS technology gives you an absolute measure of fluid volume. It uses electromagnetic radar to beam right through the right lung, and it takes 45 seconds. We do this measurement multiple times a week in my practice. And it really does. It takes about 45 seconds once the machine is turned on to get your answer. Normal lung fluid volume will give you a measure of 20 to 35%. It's done on top of the patient's clothing. They don't have to undress. It doesn't have to be direct skin contact. It's not heavy or invasive. It's very easy and quick. Patients don't mind doing it, and it gives us some fantastic information. And it's not hard to use this machine. I will tell you as a PCP, one thing that worries me is bringing technology into my office that is so finicky that I have to have very skilled people to use it correctly to give me a correct reading. And I have that issue with some of my machines, like my PTINR machine or my hemoglobin A1C machine. Technique is different for both those. It has to be done exactly correctly, or you could get a wrong result. This machine is pretty easy to use, and we have people in our office trained from the greenest CMA up to a registered nurse. They can all use it, get similar results. It's very user independent, which I like as a PCP. Next slide. So again, you get this really clear number between if they're normal, euvolemic, they're going to be between 20 and 35. If they're less than 20, they're probably over diuresed. And if they're over 35, then they're in fluid overload, possibly, and you need to make your decisions based on that. Next slide. So when do I use this machine? It is absolutely fantastic for routine management of heart failure patients. I use it when those patients come in for their chronic visits. We just grab a measurement, it's quick, and gives us on our flow sheet a way to track that patient to know what their typical reading is. It is fantastic in the post-discharge visit. If you use this machine for a while, you will realize that most of the patients that come out of the hospital after a heart failure admission are still volume overloaded when they hit your door. And that is very important because if you don't manage their fluid volume correctly, they'll end up back in the hospital. That's why heart failure has such a high readmission rate. You use it when you're not sure what's going on. Patient has very vague symptoms. You're not sure, is this their heart failure? Is this COPD? Is it nothing? Put the vest on and find out. And then I've also used it in those scenarios where patient doesn't have a diagnosis of heart failure yet. They're coming in with suspicious symptoms to me, like fatigue, maybe shortness of breath and exertion, and I'm starting to work them up. In my office, if I try to get a pro-BNP, it's 1 to 2 days before I get that back. That patient could be hospitalized by then. I use it in addition to my other workflow, my other workup techniques, and it helps me decide, could this be heart failure? Or no, the patient's completely euvolemic. I don't have to worry about heart failure. I need to be thinking about a PE or a COPD exacerbation or something else. So it rules in and it helps rule out. Next slide. So I'm going to give you a few cases as examples of where the vest can be helpful. This gentleman is a 72-year-old male. He has high heart failure with preserved ejection fraction. He comes into the office. It's a routine follow-up. He has mild fatigue only, no edema on exam, and his weight's stable. You look at him, you do not have any technology to use. You look at him, he looks fine. Follow up in 4 weeks. 5 days later, the ER is calling you. Mr. Smith was admitted and he's in frank volume overload. He's going to the ICU. Could that have been prevented? Well, let's take a look. Next slide. Okay. Same patient comes into your office. You look at him again, clinical signs minimal. He's got some vague symptoms. This time, you put the vest on him. You realize his reading is 54. You can adjust his diuretics, see him back in 48 hours to measure him again, see where he's at. Maybe he needs a little more diuresis. Measure him again. Over 3 days, you get his fluid status normalized. He stayed out of the hospital. He's happy as a clam with you because the hospital has terrible food and very poor TV channels. And he's happy. His family's happy. The hospital didn't have any beds, so they're happy that you kept him out of there. And your value-based risk contract is happy too. Next slide. Every heart failure admission, by the way, is about $10,000. And when you're in risk-based contracts for value, that hits your bottom line. So let's look at another example. This is a 78-year-old male, and he has COPD and CHF. He comes into the office and he's short of breath. His SATs are 93% on room air. He's got bibasilar crackles and a few scattered wheezes on exam. That's how he often sounds in the office. This is my real patient. He has mild chronic pedal edema at baseline. There's no change to down exam. His weight is the same. You give him a neb, there's no improvement. Is this his heart failure or his COPD? Not sure. But the REDS vest on him is reading as 54%. So I know that he's volume overloaded. We adjusted his diuretics, saw him 24 hours later. His REDS vest was already down to 37. He was feeling better, saw him again in 24 hours. His REDS vest was 32%. That's pretty much his baseline. And we again avoided the ED and probable admission. This gentleman had not been coming to see me. He was just, previous to this, he was just going straight to the ER. And every time he went to the ER, he got admitted. Every single time. And he had had something crazy like 12 admissions in 3 months. And then he landed on my patient list with our value-based care contract. We reached out to him, got him established with us, and he has not, let me knock on some wood, he's not been in the hospital since then. Next slide. This is another favorite patient of mine, 74-year-old male. He has systolic CHF. Unfortunately, he also has stage 4 chronic kidney disease with reduced ejection fraction as well. He had had multiple hospitalizations for CHF exacerbations, treated outpatient by his prior MD. And what would typically happen was he would get over-diuresed and go into a little bit of an AKI overlying his chronic kidney disease. He came to our practice to establish because one of his retired military friends suggested that our office had some technology that could help manage him better. And this was over 2 years ago. This gentleman, we started him on weekly REDS readings, and it took a little while. It was kind of hard to get him adjusted because his CKD interfered with his CHF. And this is a good place to explain that keeping these flow sheets on patients will tell you where they need to be because, the average patient tends to run in the 20s, maybe around 30, 31. But this gentleman typically runs at like 34 and maybe even 35, 36, but I can't tighten him too much because of his chronic kidney disease. He will end up in overt failure. So I'm sorry, he will end up in worsening his kidney function. So we got him on serial weekly readings. We adjusted his diuretics, found the sweet spot, added a little dietary education on sodium. Over time, we were able to get him to where we were only having to measure him monthly. His renal status ended up improving about 10% because we weren't constantly stressing his system with excessive diuretics. And he has not been hospitalized in over 2 years and counting now. Next slide. So, key takeaways from my standpoint. Early heart failure, when your window is best to intervene in these folks, it's very subtle presentation. Your classic signs are often absent. And the traditional things that we use, laboratory data and is too slow, and the physical exam signs will often miss mild early congestion. So it's great to have something can give you a quick, objective, easily repeatable measurement that can change your intervention plan and really keep people out of the hospital and out of the ER. And in this day and age, PCPs, we need to be the ones managing this condition. We need to be on the front lines and we need the right tools to be able to manage these patients.